It's a real pleasure today to introduce a team who's going to talk to us about a very important topic for all of us and our patients, which is palliative care, representing two different groups, two related groups, the UNC Palliative Care Group and the Schwartz Rounds. And this is going to be a multi-speaker, I don't know if it's multimedia presentation. So I know we're in for a lot of information and look forward to this very much. I think Steve Bernard is going to lead things off. Thank you very much.
Thank you, Marshall. We're going to be discussing some issues related to palliative care, and this is really to showcase two programs here. It's the Palliative Care Program, which has been going here since 2002, and Schwartz Rounds, which has been going since 2003. Is that correct? Yeah. And so I've put up the names of the individuals who are going to be speaking today, and I'm just going to say a few words about the programs. There we go. So the Palliative Care Program, which has been in existence here since 2002, started with the Duke Endowment Grant. It is an interdisciplinary program. It has members from two divisions in the Department of Medicine and from the Department of Surgery, from social work, and from nursing. Is Walter Chip Baker, who is our nursing coordinator, who you'll meet today, and myself, Tony Caprio, and Gary Winselberg and Laura Hanson from the Division of Geriatrics, Renee Stafford from Surgery, and June Dixon, our social worker. Can get this to work. All right. This is not what we want. Where's the, let me go to something more familiar. Yeah, let me go, let's see, how do we do this?
Let me just get this
Yeah,
real
why
quick.
don't you get this to newer.
Sorry. Yeah, it's,
Oh, it's over there. Okay, I can,
so right click is back
okay.
and left click, and the one you hit is the one in the middle that's the disaster button.
Yeah, that was the disaster button. Okay, all right. Okay, so palliative care has come along in the United States over the last couple of decades. We wanted to just briefly distinguish this from hospice, which many people are familiar with. Hospice in the United States since 1973 achieves Medicare payment, Medicare benefit, the hospice Medicare benefit, for the last 6 months of life. So individuals have to be certified by a physician as being in their last 6 months of life. So there's typically a long period of time in which treatment is done to cure or treat disease, and then the patient abruptly moves to hospice. After death, there's bereavement care in that scenario. On the other hand, palliative care, which has been a feature of the English-speaking world for several decades now, can be done at any time during the disease course, even when there is active treatment of the disease. It's to reduce symptoms, to relieve suffering. And so it spans both the period of time before the last 6 months of life and the period of time after death with counseling for the family. Schwartz Rounds, the two individuals who have been working hard to do Schwartz Rounds here and very successfully are Dr. Fran Collichio and Dr. Teresa Raphael-Grimm, who is the facilitator for Schwartz Rounds. And Schwartz Rounds began at the Mass General. It's a multidisciplinary forum where, as you can see, caregivers discuss difficult emotional and social issues that arise in caring for patients. It is a multi-institutional event now at many of the leading institutions in the United States, and we have been a participant as well as one of the leading institutions in the United States. It's interactive, it's interdisciplinary, and it tries to focus on issues which are not necessarily the classic medical issues. I'm going to say just a few words now about palliative care in general. When we look at patients, and there are several reviews in the literature, several prospective studies with life-limiting chronic illness, often their goals are articulated. As you can see here, this is from a study that was done at the Durham VA. They want adequate pain management. They want to avoid the prolongation of dying. They want some sense of control. They want to relieve burdens, and they want to strengthen relationships. Dr. Hanson has published data from this institution with 461 recently bereaved individual family members of former patients. And again, high on the list is time with the physician, pain management, but also communication skills. And we put in here a quote from one of our patients' families about the kind of things that are important at this point in their lives. What we're going to be talking about today are the items that I've listed here. There's myself. Dr. Hanson is going to present a case and discuss pain and physical symptoms. Dr. Teresa Raphael-Grimm is going to talk about communication. And Chip Baker, the nursing coordinator, will speak about goals of care and decision making. I'm just going to introduce each one of them briefly and then let them take over. So Dr. Hanson is an associate professor in the Division of Geriatric Medicine and is a co-director of the Palliative Care program at UNC. Dr. Teresa Raphael-Grimm is a psychotherapist in the Department of Psychiatry with joint appointments in nursing and medicine, in the schools of nursing and medicine. And Chip Baker, Walter Baker, is the nursing director of the UNC Palliative Care program. He is an advanced practice nurse, certified in palliative care, and has also taken the LNEC course, which is a Nursing Education Consortium end-of-life course, which is a national certification. He has received his nurse practitioner education at the Columbia University School of Nursing. And so I'm going to turn this over now to Dr. Hanson and let her go forward.
Great. I think our microphone is actually not on, but hopefully y'all can hear me in the back. And if not, you can move forward. All right, I'm going to briefly go through the case presentation. The patient that we're going to use as the frame for this discussion is a 59-year-old Caucasian female with a history, an underlying history of diabetes, which was then complicated by end-stage renal disease, who subsequently developed the complication of calciphylaxis and both abdominal and sacral ulcers. She was admitted, one of numerous admissions to UNC hospitals, and the admission that we're discussing in this presentation, the chief concern triggering the admission was hypotension, with systolic blood pressures in the 68 to 90 range at the time of admission, and she concurrently was complaining of severe pain. Fairly quickly after admission, she was diagnosed with OSSA bacteremia, was treated for that appropriately, and then subsequently developed ORSA bacteremia. And this was an ongoing phenomenon, treatment for recurrent infections in her history. It's also notable that her low blood pressure was initially attributed to bacteremia, but her blood pressure remained essentially unchanged after appropriate IV antibiotics. Past medical history is also fairly complex. I mentioned her end-stage renal disease. She was on chronic hemodialysis at the time of presentation and fairly recently had begun to require stretcher-based hemodialysis because she was judged to be unable to sit up due to her low blood pressure. She had a history of calciphylaxis that dated back approximately 6 months, with the development first of necrotic abdominal wounds. Those wounds over the 6-month course had been treated with multiple surgical debridements. Many different types of dressing changes were attempted. She had 2 wound vacs placed, and she was residing in a clinitron bed. All of this aggressive treatment for her wounds had resulted in partial healing, but at the time of presentation, she had developed a new necrotic wound in the sacral area. Looking back through her UNC records, she was a frequent flyer, frequently coming to medical attention. She had had 9 admissions in the preceding 6 months, and these were for hypotension, for pain management, for lower GI bleeding from diverticular disease, and for episodes of fall with trauma. She also had a background history of obstructive sleep apnea and was not currently using any form of pressure support in order to support her breathing. She had a history of depression and anxiety, and these were on active treatment at the time of admission, but in recent weeks she had poor oral intake and had experienced a weight loss of 25 pounds. Social history was also relevant. She's a widow, was currently residing in a local nursing home. She had primary support from both a son and daughter who lived reasonably nearby, but were very busy and occupied with raising families, and so tended to see her relatively infrequently. And by report, she lived a fairly sedentary and reclusive lifestyle even prior to becoming as ill as she was at this presentation. Here's her medication list at the time of admission. I've highlighted the top 3 agents because those are her pain medications at the time of admission, and I'll talk a little bit more about management. But one thing I want to point out on this list is that the vast majority of the medications that she was on are really medications that were targeted toward management of symptoms. The first 3 medications on the list, her fentanyl, hydromorphone, and methadone doses, were being administered for her chronic severe pain from wounds. She had clonazepam and sertraline for treatment of her depression and anxiety, which were partially ameliorated by those agents. She was on modafinil for both actually true sedation during the day. She tended to have daytime drowsiness and her sleep apnea. And then she was on a number of medications designed to treat her underlying calciphylaxis and the resulting wounds. She also had the symptoms of constipation and intermittent nausea, and she used medications on a PRN basis for those symptoms. Here's her pain regimen after admission to the hospital, and just to point out that because of her hypotension, her pain regimen was significantly reduced at the time of admission. She had been on a fentanyl patch of 150 micrograms, and this was reduced to 25. Her hydromorphone dose had been a 4 milligram dose, and this was reduced to 2 and placed on a PRN rather than a scheduled basis. And her methadone was maintained at her outpatient dosing level. On initial examination, she was an obese white female in acute distress related to physical pain. Her systolic blood pressure was 76 and she was tachycardic. Most notable on physical exam relative to her pain complaint were her large wounds, which covered significant areas of her abdomen and sacrum. She had no initial signs at the time of presentation of active infection in those wounds, but did have wound vacs that had been applied as part of her treatment. Musculoskeletal exam I'll just represent by indicating that she was profoundly weak. She was lying in a clinitron bed and unable to lift her limbs against gravity, and furthermore, unable to turn herself from side to side, which she attributed in part to the pain of even simple movements like attempting to turn. And on her laboratory assessment, I'll highlight that her serum albumin was 1.5, which was consistent with her history of nutritional decline. In doing a complete pain assessment, it's important not only to understand pain severity, which for this individual was 10 out of 10, no matter what scale was applied, but also to know a little bit more about the pain experience in planning for management of the pain. The location was really in the distribution of her wound sites, and she really described a purely somatic type of pain with a stabbing character. She had been in this level of pain for months of time, so this was an extended experience for her, and the pain was constantly present. It never left, no matter what kind of treatment was currently being administered in the hospital. She did recognize that in the past, when she had been treated with intravenous hydromorphone, this did give her more relief than some of the other agents that she had received. And it was clear to her that any form of movement, and very specifically dressing changes to the wound sites, were the worst triggers for escalation of her pain. It's also important in pain assessment to understand what it means in terms of the patient's function. This was an individual who had obviously experienced a pretty profound functional decline, which could be attributed to multiple characteristics of her complex medical illness, but In addition, the pain itself was affecting her mood, giving her an experience of hopelessness, and making her functionally debilitated to the point that she was unable to turn in bed. It also had an effect on her interaction with healthcare providers, and very specifically, she would frequently refuse to accept dressing changes, the primary treatment for the underlying cause of her pain, because the dressing changes themselves caused the pain to escalate. The etiology of her pain was also not very difficult to determine. It was really her calciphylaxis, a fairly uncommon, fortunately uncommon, complication seen in end-stage renal disease patients in whom, for reasons that are not entirely understood, a progressive calcification of arterial circulation results in the development of areas of necrosis and progressive wound development. The individuals who develop this condition can be very, very difficult to treat. She had been treated quite aggressively, both in terms of medical management and in local wound management, in an effort to promote healing in these sites, but understanding that the pathophysiology is underlying difficulty with arterial circulation. These patients, not surprisingly, are at high risk of sepsis, and that had proved to be true in her situation, and also at high risk for dying from complications of their wounds. The therapeutic evidence for primary treatment of this condition is really limited to case series and case reports in the medical literature, and she had been tried on many of the options that are available in those case series for treatment. One of the primary concerns in this case presentation and in her management was concern over side effects from opioid medication. The extraordinary severity of her pain and persistence of her pain meant that the opioid class was really the primary class that we needed to turn to in order to manage her pain. But some of the potential side effects of opioids were concerning, including sedation, respiratory depression, and hypotension, for all the reasons that you can immediately pick up on from knowing the history of her presentation. She already had difficulty with daytime sedation, partly perhaps due to bacteremia and hypoactive delirium, partly due to medication side effects, and perhaps partly also due to her obstructive sleep apnea. This is a relatively common side effect of opioids, but it's a side effect that generally, for which tolerance generally develops over time. So when individuals are on a chronic stable dose of opioid medication, they will progressively develop tolerance not only to the medication's analgesic effects, but also to the sedative side effect. There are very limited studies of secondary treatment to try to limit sedation as an opioid side effect. So I don't want to claim that these are actually effective therapies, but modafinil, which she was actually on, methylphenidate or donepezil, may ameliorate some of the sedative side effects of opioids. Respiratory depression is probably the most feared side effect of opioids, and clearly a concern in an individual that already has obstructive sleep apnea. Individuals who take high-dose opioids will develop some changes in their respiratory drive in response to hypoxia and also to hypercarbia. But it's important to note that sedation typically precedes this feared side effect. So individuals who are not profoundly sedated by the opioid dose that they're currently taking are unlikely to develop respiratory depression, and we generally can titrate opioids in that way by monitoring for sedation first and looking for respiratory depression as a side effect that would follow rather than precede sedation. And then finally, hypotension is a potential but relatively uncommon adverse effect of opioids. So in her circumstances, the most immediate threat was her relative hypotension, but the probability that her opioids would accelerate her difficulty with hypotension was relatively low. doesn't mean it was easy to balance. And then finally, I want to make a few comments about renal disease and the use of opioid medication. This was a further complexity in medical management of her pain. Because of her end-stage renal disease, she is an individual who would excrete opioid medications in a manner different from individuals without renal failure. With the exception of methadone, all of the other opioids that we commonly use are first hepatically metabolized and then renally excreted, and the metabolites that circulate after passing through the liver, those metabolites have varied levels and actions in the human body. They can have analgesic effects, but they can also have toxic or adverse effects as they circulate. Morphine is probably the best understood of all the opioids that we commonly use in terms of its metabolism, and morphine 6-glucuronide is known to be a potent active metabolite of morphine. It's renally excreted, as I mentioned, all of these metabolites are, and in the case of morphine 6-glucuronide explicitly, this is a metabolite that is very slow to cross the blood-brain barrier. As a consequence, there is a delay in the central nervous system toxicity of morphine when it's administered, and excretion of morphine with relief of the sedative side effects that this metabolite may have can be delayed, and even more profoundly delayed, in people who have renal failure. In general, we recommend that individuals with renal failure not use nonsteroidals, tramadol, morphine, or codeine for reasons of the adverse effects of either the primary drug or the metabolites. And it is generally safer in individuals with reduced GFR to use hydromorphone, oxycodone, methadone, or fentanyl, which will have fewer difficulties in terms of the effects of metabolites. In dialysis, things are a little bit different. So this is an individual who not only has end-stage renal disease, but has progressed to the level of using dialysis. And once an individual is on dialysis, it's important to understand that some opioids are more dialysable than others. And in general, we recommend primarily the use of hydromorphone in this population because of its better removal in dialysis. So in terms of recommendations for pain treatment in this individual, clearly a balancing act, clearly a fine line to walk in terms of concerns over adverse effects and her ability to eliminate any opioid medication, but at the same time concerns that her excruciating pain is causing not only daily suffering, but impeding her ability to participate in dressing changes or in even turning in bed or getting up. We recommended avoiding the use of any other forms of sedatives. The clonazepam, being a strong sedative, may simply have an additive effect that gets in the way of pain treatment. Some of her anxiety, in fact, could be related primarily to depression or even to untreated pain, and rather than treating it primarily with an anxiolytic, it may be more important to treat the pain itself. In this context, in the context of both difficult to manage potential adverse effects and severe acute pain, it's most appropriate to use intravenous medication for acute titration, both to gain rapid control over the pain, but also to have control over moving the dose up and down in a rapid manner. The two long-acting agents she was taking, transdermal fentanyl and methadone, are both agents that have very long half-lives once in place and can be extraordinarily difficult to titrate in an acute care situation. And then finally, we recommended reassessment of the risk and benefit of different pain triggers. One of the strategies in pain management is to reduce the things that make the pain worse, and her wound vacs and dressing changes were things that we recommended reassessing. Now I'm going to stop and turn it over to Teresa Raphael-Grimm.
Okay, I got involved with this case because the psych consult team was called in to see whether or not the patient had capacity to make decisions about not receiving wound care. And they found that she did have capacity to make that decision, but asked if I, as the psychotherapist for the team, would come in and help her develop better insight as to how it was that she was refusing that care. Going the wrong way. Okay, got it. When I interviewed the patient, what was so striking about her was that she clearly said that receiving wound care to her was torture, and that in order to agree to submit to the wound care, she had to agree to a level of pain that was absolutely overwhelming for her. She clearly understood the need for the wound care, and she did understand that by not receiving that care, she was placing herself in a position to ultimately die from complications. What she wanted was for the wound care to be, if not pain-free, at least pain tolerable, and that clearly her low blood pressure prohibited her from receiving more aggressive pain management. However, what was striking about her is that she did want care in general. She wasn't in general refusing the care. So by refusing the painful wound care, she was essentially not allowing the healing to occur. And in doing so, she was essentially refusing the efforts of the physicians and the nurses. And some of the treatment team members were actually getting quite concerned about the fact that when they would go in to try to convince her to receive this care, that she would come across as angry and irritable. Given her level of pain, it wasn't surprising that some people express that through their irritability. And there was really a disconnect between what she experienced in terms of pain and what the team seemed to understand about her level of pain. And pain being one of those subjective things, lots of folks believe that, well, is she really in that much pain, or could she be exaggerating that? Could she be, there's always the question of secondary gain. But to my mind, in working with her, it was clear that she experienced this pain as torture. And as long as she did experience it that way, she was going to be much less likely to comply. What happens when folks do this is they often then convey to the team a sense that perhaps the appropriateness of the care is called into question. And what that does is that it creates all kinds of management complexities from an already frustrated staff. So clearly there were divergent perspectives in this case. The team wanted the patient to utilize the most effective care possible, and for them that was the wound care. The patient wanted wound care, but in a pain-free form. She did vacillate between competing desires and goals. At times, she would say that if they could just make the pain slightly more tolerable, she would do it. And then other times she would say, you know, I'm so tired of all this that I really don't know whether I can stand anymore at all. She did elicit difficult emotional responses in the caregivers, and there was this kind of sense of breakdown in trust. Again, her goal was to get pain-free care. The team's goal was to provide effective care. Her perception was that the providers became frustrated when she expressed the intensity of her pain, her desire to discontinue the wound care, and her doubt in the care itself. So we thought this would be a good case to illustrate some of the things that often come up in the more subtle aspects of patient care. That clearly, when a patient is refusing what the team believes to be in her best interest, it's easy for people to get annoyed and frustrated. And clearly, the nurses were able to say pretty clearly that they really believed that this was her only chance to get better, and that by refusing it, she was not going to get better, and that this was creating a sense of ethical dilemma for them. There's also the resentment, the self-doubt, that as providers, people then say, well, gee, if we're recommending care that this person doesn't want or agree to, then are we really adequately addressing the situation? Certainly what can happen is that in these kinds of cases, there can be almost a withdrawal of investment in the patient's care, as evidenced by things like less frequent visits to the room, people avoiding the patient or the patient's questions, et cetera. And then there's also the issue of, in complex medical centers where lots of people are watching other people's treatment, there's that sense that, wait a minute, are we doing everything we can, and I don't like this case being called into scrutiny, and if this patient would only agree to the treatment, then that scrutiny wouldn't occur, et cetera. And sometimes this can culminate in a misattribution. The treatment failure is seen as primarily due to the patient's behavior, rather than a complex situation that requires just much more detailed thinking. There was an article this week in the New York Times by a psychiatrist who wrote about how common it is when patients seem to be resistant to care or don't respond the way we hope they will, to blaming the patient. In this situation, I thought it was helpful to look at care from a broader perspective. And oftentimes, especially in a complex university system like ours, we often think about care as pharmacological, technical, or mechanical events. But sometimes all of us are challenged to remember that care extends to the more subtle and sometimes overlooked aspects of human healing. And that when we feel our compassion start to wane, or that investment begin to deteriorate, certainly it's time to look at emotional reactivity and examine underlying dynamics with the patient and caregiver relationship. And, we talk about compassion a lot, and I know there's a major effort in the hospital to look at caring and compassion across all the specialties. And compassion isn't just one thing. It's kind of a complex experience that can build and develop in a relationship, but it also can wane as well. And clearly challenging situations and complicating factors influence compassion, that it's easy for communication to break down. And there's also those interpersonal landmines that often come up where if there's any implication or even in any way where it's even subtly implied to the patient that if they just buck up, they can withstand the pain of the treatment or whatever, oftentimes that can be perceived as to the patient as not being believed. And oftentimes there are seemingly competing needs and interests, not to the least of which is time, and how time-pressured people are to attend to a patient and move on to the next one. And yet it is within the relationships between caregivers and patients where much of the healing happens, whether or not the patient lives or dies. And this is the stuff of Schwartz round. So this is what Fran, Collichio, and I do every month, is kind of to take on some of these thorny issues and present them and dissect them and really look at what happens in those relationships. And Chip is next.
So I remember early on in my career as a caregiver working with an HIV population, and there was a patient of mine who decided not to take his antiretrovirals anymore, and I was having difficulty trying to tease out why, and trying to convince him this would be the best thing for him. And his doctor finally came in and sat down on the bed and said, very point blank, do you want to live or do you want to die? And I was really taken back by that. The patient said, of course I want to live, and so it was decided that he would continue with his antiretroviral therapy. But for me, it's at that point, it's really all about the questions that you ask the patient. Some questions have an obvious answer. Do you want to live or die? Well, who wants to really die? The cliche question, do you want everything done? Of course I want everything done. So we have to be a little bit more specific in terms of the questions we ask. And for the big picture question for our patient was really, do you want to continue the course that we're doing in the hospital with aggressive antibiotic therapy and wound care? Or would you like to focus more on your comfort and maybe forego dialysis, seeing that your prognosis is poor? And this question wasn't as obvious as the first two I threw at you. It was kind of paralyzing for the patient. It was kind of these rock and hard place questions that you ask the patient. You're choosing between, a course of treatment that's going to be excruciatingly painful, or you're choosing, in all inevitability, death. Which do you choose? And it's very difficult for the patient, and I think frustrating for the team that answer wasn't, after a lengthy time of reflection, wasn't apparent to the patient. So it's really all about trying to negotiate find out who the patient is in that bed, and negotiating what the options are and what they would want in the situation. And so defining goals of care is what I'm going to talk about a little bit. And like Teresa said, it's all about communication, and it takes time and it's hard work. I don't know, all of you who have been in a family meeting that lasts about a half an hour, and you're wiped after that meeting. You want to go home and just have a drink or sit in the hot tub or whatever. You don't want to stay at work. It's hard work. So how do you get involved in the case is very important. How do you gain the trust of the patient over time? And these are dialogues that are ongoing and don't happen on day one. Gaining trust is most important with really having a frank discussion about life and death situations. And it's all about negotiating treatment options. Maybe the wound care was maybe prolonging her life, but maybe wasn't the best thing for her, and maybe would not change the outcome dramatically. And that needed to be voiced to the patient. We need to be honest with truth-telling, obviously, the situation, the big picture, the prognosis, the treatment, what really is the endpoint of these kind of knee-jerk reactions to wound care from a nursing perspective. Wound care, three times a day, turning every 2 hours. They have protocols that Joint Commission comes in and they want to, they have to see that we're adhering to these protocols. Well, maybe it's time to look at them and maybe be a little bit more flexible. So for our patient, her goals were not dramatic, like I want to live for another 10 years or I want to get off of dialysis. Her goals were, I want to get out of this bed and sit up to eat my dinner. She literally had a tray of food up to her chin that she had to sort of eat with. She wanted to have more time with her family. She wanted to maybe sit up on the side of the bed so she could have a little bit more mobility. Not dramatic goals, but very subtle and personal goals. So communicating goals of care. Very difficult stuff, because we know that what patients and families hear are different from in terms of what I say or what the next person says, or even from what I say from day to day. And what they hear and what they process is totally different as well. We assume a lot of things from patients. Patients may be willing to live in a physical state that others would seem totally unacceptable. So you go in the MICU and you see the patient that's hooked up to every bell and whistle, and they've got a tube in every orifice, and you say, not for me. I don't know why that person and that family is still enduring that. Well, maybe for that person, that's an acceptable state of living. Tolerance for treatment burden is very individualized. And we're not able to predict patients' choices for things like resuscitation. So we need to continue to ask the questions. A lot of barriers are thrown up from everywhere in terms of having these frank discussions. The patient is processing a lot of information under a time of extraordinary stress. So there's a lot of misunderstandings, a lot of miscommunication, and consistency of message is paramount. There are biases. There's a lack of experience with death, or there's maybe an experience of death that was very bad that they're reliving. Different family roles are changing. Children are now making decisions for their parents. No support systems. Our patient was physically exhausted from wound care, but also emotionally drained. She didn't even have the strength to have the lengthy dialogue or to even try to figure out what we were talking about. Very strong emotions, and of course, the culture comes into play in terms of our preferences. For us as providers, we have our own experiences with death, either personal or professional, that may shape the way that we handle our patients. We're under an emotional roller coaster during the day with the patients and our coworkers that we experience. Fatigue comes into play. This patient was in the hospital for over 58 days. So imagine going in day after day after day and having this talk and really kind of making minimal strides in terms of negotiation. It's very, very draining. Our own personal values, our fears as bringers of bad news, our fears that we're not really familiar with having these talks, we don't have the experiences, and then the one that I think is very prevalent is this prognostication, and we have a tough time looking into our crystal ball and seeing how much time the patient has. So of course you don't feel any better. 2 years ago I gave you 6 months to live, now you do the math. So it's really, how do we talk about big picture questions when we don't really know what the big picture is going to hold for this patient? How do we expect them to make decisions based on accurate prognostication if it's so difficult for us to come up with time frames? And then of course there's system barriers, time, new teams coming on, new attendings, with different, again, bringing their own different barriers back into the play. No privacy for rooms, we're interrupted all the time, and maybe a lack of valued opinion. So preparation is really key. Knowing what the facts are, reviewing the chart. I have lab values here because sometimes families and patients are really focused on, what was the hemoglobin yesterday, or what was the blood gas this morning. So have that information available. Discuss the situation with all the teams. Nursing is invaluable in terms of getting their perspective on what the patient is dealing with. They have these intimate conversations at 3 a.m. that you may have no idea that are going on. They're a good resource for you. Physical therapy, how's the patient doing? Do they glean anything psychosocially from the patient while they're working with them? Dietary, have a game plan, all the teams be on the same page. Patients who are in the hospital for a long period of time, it's important to have certain key members who will deliver the information so there's no misunderstanding, there's no miscommunication in the process. And then likewise on the family side, have one person receive the information and be the disseminator, 1 or 2 people, not a whole room of 17 people every day after day after day, because that's where you get into trouble. For meetings, set a time and obviously plan to show up, because abandonment is very important to not go down that road. So what information do you need? Obviously diagnosis, hopefully a pretty good idea of prognosis, treatments and treatment alternatives. What are the risks? What are the benefits? And you guys know all this. You need to spend time, again, exploring quality of life, and that's a vague term, what quality of life is, but what are your goals as a patient dealing with this illness? What are your values? What do you see as your goals of coming out of this hospitalization? Make sure that you're sure that pain and symptom management will be in the picture. regardless of the decision. There's no reason why we can't handle that as well as going down the treatment road. With this woman, we had maybe the same answer to every question day after day. So we had expected, anticipated decisions. So we need to have contingency plans based on those repeated decisions, or contingency plans based on an answer to a question that totally came out of right field. And obviously, during the dying process, we want to assure that there's going to be support not only for the patient, that we address fears, but there is also going to be support through family and friends. So for our patient, her goals of care were, she wanted to live a little longer. She said she wasn't afraid of death, but she wasn't ready to die. She wanted to have some improvement in function, to be able to sit on the side of the bed. She obviously wanted her relief of suffering and her pain. She wanted, and she felt that that was contributing to a poor quality of life, so she wanted improvement in that aspect. She felt she had no control at all over the situation. She would come back from dialysis, and her PCA, or her PCA pump button would be over here, her call bell would be over here, and her TV, which she loved to watch, would be up against the wall, and she'd be put in bed, and the door would be closed, and people would walk away. And we would come in, and she was like, everything was out of reach. So she wanted a little bit more control. She did want to go home. She didn't want to be in the hospital. And she particularly wanted the support of her son, who was having a lot of trouble with decision-making and supporting his mother. So don't be afraid of silence. 80% of communication is nonverbal. Don't abandon the patient. Don't make promises you can't keep. Again, this all helps to foster trust, and don't give false hope. But what you want to do is you want to explore the goals, the hopes, the expectation, but also the fears of the patient. Address their emotions, no matter how occult. Go down that road if you feel it needs to go down, be gone down. Be consistent with your words, develop a plan, and always follow up with the patient. The big two that I use in terms of talking to the patient is, before leaving the room, I always say, what are your biggest concerns right now? What can we do for you? And/or what is the hardest part of this for you and your family right now? Because it's most times that the fears are paralyzing the patient, and they're unable to come up with any decision. And then we have the hoping and preparing. We're hoping for the best for you, but I think at the same time we need to prepare for the worst in case things do not go the way we planned. Steve, do you want to do the resolutions, or? Okay, so the resolutions of this long and frustrating case were that she stated that she wanted to go back home, be able to walk, to sit up in bed, and to be in less pain. Psychosocially, she stated that she was depressed and she feels she's in a difficult situation, and again, she's not ready to die. We removed the wound vacs that helped with her pain. We increased the use of IV hydromorphone for pain. We switched her to PCA, which helped. We finally decided that, well, actually it was decided that her hypertension was so significant that dialysis was really not an option for her anymore. And she actually died quite quickly, after, maybe a day or two after with the stopping of dialysis. She did have a comfortable death, and it allowed her son, her granddaughter, her son and her daughter and her grandchildren to visit before she died as well. So, conclusions. Pain relief is necessary or pain relief and symptom management is necessary, the first step to discuss other issues. We need to make her comfortable first, because that is going to be a barrier for further dialogue. We need to expand the definition of what care is. It may not be just a blood test or an MRI or hanging antibiotics or doing wound changes 3 times a day. And in difficult and complex cases, negotiation is really a strategy that has to be discussed with all players of the IDCP team. The patient and the family may have values and goals other than maximizing survival, and those that dialogue has to continue. And then I leave you with this: nature gave us one tongue and two ears so we could hear twice as much as we speak. And I'm going to open it up for any questions or comments. That's a very good point. She had actually voiced to us that I'm tired of everyone coming in the room and telling me that I'm going to die. I know I'm going to die. So sometimes we want to have the dialogue and we want to be frank and open, but that hammering of that point, the major point, can be just overwhelming to the patient. I think patients are going to have unrealistic goals based on the situation. I don't think necessarily you have to say that they're unrealistic, but I think you have to sort of pull them back a little bit and say, well, if that's a goal, okay, but let's work on this. Let's try working on this first. I don't know, Laura, would you have?
Yeah, I was just going to add that one of the things that was actually helpful was that she had multiple goals, and it meant that it was useful to work on the ones that could be worked on. And that was a way of building trust and relieving suffering, even when some goals did not appear to be achievable.
We have a system, as we all know, where there's less and less continuity of care, particularly over the long term. The physician who knows these patients over the long term, and people coming in and out constantly. I just wondered what your perspective is on situations where you can compare when you do have such a person who does know this person over 10 years, and how that impacts just how how it makes it easier or harder.
I'd just like to address that briefly, and that's that sometimes we talk about that in Schwartz because what we find is that the lack of continuity of care means that there's no single person who's the repository of the patient's history that extends beyond their medical history. And so, who matters to them in life, who are key people, who they might rely on for advice, input. It is helpful if there is a primary care person who has been involved to stay involved, or for us to have them get involved during the process. Oftentimes that person doesn't exist, but should they, that's critical to helping this individual get through this.
I'm wondering if there isn't a huge opportunity in general to have hospice go around with every patient in the hospital. Because what happens in a lot of cases is that we're so focused on trying to get through the day, through all the documentation, that I think the issues that you bring up with this particular case actually apply to almost every patient that we see in this hospital every day. People are completely isolated sometimes because they're scattered over the hospital, away from the team. That teams are really terrifically overburdened. We have house officers having to have a day off because they're getting headaches, depression. If the staff and the institution is so pressured that they're not being cared for, that has to reflect on how they come across the patients as well. So I'm wondering how you restore some of the humanity to, when 4 a.m. blood draws would get the 5-year-old kid out by 9 o'clock in the morning. I'm wondering if this doesn't need to be a routine part of operational decisions.
I think that the routine and the sort of systems-wide basis of your comment is part of the answer hospice will not be rounding in the hospital anytime soon, so that's not going to happen. Our palliative care team is available to do consults and to work closely with the primary teams in scenarios that are more challenging and more difficult and complex. And that can be helpful. But the reality, I think, that you've addressed is that many of these issues arise in the care of every patient, certainly on the medicine services. I can't speak beyond the medicine services, although we see it on other services where we consult. And it probably does need to be thought through at a systems level as well, in education and training and in the way that we deliver care. One of my favorite strategies when I'm ward attending instead of consult attending is to ask why we're doing a 4 a.m. blood draw, for example. And I think there are ways that we can think about delivering care that attempt to address some of these bigger picture issues. Doesn't solve the problem of time and intensity.
Let me just thank our speakers. Maybe it's a little after one, so if there are more questions, just come up. But thank you very much for your presentation.